Go.
So, good morning sir. Ako po si Dr. Paz po. Ang gagawin po natin ngayon ay inyong abdominal examination. So, first thing that we will be doing is inspection. So, we check for the abdominal circumference first. Be careful for the metal part of the tape measure because it will hurt the patient. So, the abdominal circumference of the patient is 81 centimeters. So, we go immediately checking for the abdominal shape. So, I am looking tangentially, drawing imaginary line from the xiphoid process to umbilicus. So, the abdominal shape of the patient is normal. It is not globular in shape. So, the umbilicus of the patient is everted. There is no discharge, no infection, and there is no stone. So, overall, there are no lesions, scars, and subcutaneous blood vessels. There are no nodules. The symmetry of the abdomen of the patient is equal, and there are no caput medusae, and there are no bulging. So, next thing that I will be doing is auscultation. So, we do auscultation before palpation because palpation can cause hyperperistalsis and can give us inaccurate sound. So, we do it 1 minute per quadrant. We rub the diaphragm first. We use the diaphragm because the vowel sounds are high-pitched sounds. So the normal active sounds is 5 to 35. And the patient have normal active sounds. So we hear for abdominal bruit first in the epigastric area. So it is aortic bruit, and a bruit in this area can be an indication of aortic aneurysm. Next, we hear for the renal artery bruit in the left upper quadrant and in the right upper quadrant. So any bruit in this area can be an indication of renal stenosis. We hear also for the iliac bruit in the left lower quadrant and the right iliac artery bruit in the right lower quadrant. Also, we hear for the abdominal friction rub in the left hypochondrium and in the right hypochondrium. So overall, the patient have normal active sound and there are no signs of bruit. Next that I will be doing is percussion. So we are covering all the 4 quadrants again. So I am hitting the distal interphalangeal joint of my middle finger. So as we can hear, the patient have normal sound. That is tympanitic. So next I will be checking for the liver span. Our landmark here is the right midclavicular line. We start below the umbilicus for the lower border of the liver. So there is shifting of sound from tympanitic to dull. And we mark it here. Next is in the upper border of the liver. Our landmark here is below the nipple, the third intercostal. And there is shifting of sound from resonant to dull. And we mark it again here. So, measuring it is 6 centimeters, which is normal. So, next we will be percussing for the spleen. Our landmark here is the trob space. Anteriorly, the 6th rib. Laterally, the anterior maxillary line. And inferiorly, the marginal subcostal margin. So we percuss for it. So there is intact trob space. So next I will doing is fluid wave. We put the hand of the patient in the middle of the abdomen and we talk. Okay, so next we will be doing is shifting dullness. So we percuss first. And we put the patient in the cubitus position. So there is a shifting of sound from tympanitic to dull because the fluid goes down. So we put again the patient in supine position. So next, I will be doing is palpation. So we ask the patient first if there is anything painful. Sir, may masakit po ba sa tiyan nyo?
Wala.
So if none, we can do anywhere in the abdomen. So I am doing it first in the right lower quadrant. Masakit po ba, sir?
Hindi.
Masakit po?
Hindi.
Masakit po?
Hindi.
Masakit po?
Hindi.
So we can go immediately to deep palpation. Masakit po, sir?
Hindi.
Masakit po?
Hindi.
Masakit po?
Hindi.
Masakit po, sir.
Hindi.
So there is no sign of pain and I cannot feel any tumor or bulging in the abdomen. So we can do double hand palpation if the patient is obese. So now I'll be palpating for the liver. So inhale po, sir. Exhale. So when the patient exhale, it is easier to palpate to press, and the patient inhales, the pressure in the diaphragm will increase and the liver will go directly into your hand. So next, we will be palpating for the spleen. We can do by manual palpation. So there is no sign of organomegaly. We also do palpation of the kidney. So there is also no sign of organomegaly. If we are checking for the left kidney, we go to the other side. So next thing that we will be doing is special exams. So first we'll be testing for appendicitis in the McBurney's sign first. In the McBurney's point, just 1/3 from the axis. So we palpate here. Masakit po ba, sir?
Hindi.
So there is also negative McBurney's sign. So we do immediately Romberg sign. So tatanggalin ko po yung kamay ko, sir. Bibilang po ako ng 3. 1, 2, 3. Masakit po?
Hindi.
So there is negative Romberg sign. So we do immediately the Robsing sign. We deep palpate in the left lower quadrant. Masakit po, sir?
Hindi.
Masakit po?
Hindi.
So there is negative Robsing sign. So positive Robsing signs, there will be a pain in the right lower quadrant. So next we'll be doing is psoas sign. So taas niyo po yung paa niyo, sir. Masakit po?
Hindi.
So there is negative psoas sign. Next is obturator sign. Masakit po, sir?
Hindi.
So there is also negative obturator sign. So next, we do Markle sign or jaw tenderness. So ubo po kayo 3 beses. Masakit po, sir?
Hindi.
So there is also negative Markle sign. So next, overall there is no probable appendicitis for the patient. So next we test for acute cholecystitis, which is the Murphy's sign. So ipipress ko po, hinga po kayo malalim. So there is no inspiratory arrest, meaning there is negative Murphy's sign. Lastly, we check for the costovertebral angle tenderness. So tayo po tayo, sir. Tapos talikod. Masakit po?
Hindi.
Masakit po?
Hindi.
So there is negative costovertebral angle tenderness. So meaning there is intact herotas fascia of the kidney. So that's all for our abdominal examination. Thank you.